program by, for, and about women today with Sandra Elkin.
Good evening and welcome to Woman. Tonight our topic is women and heart disease. My guests, Dr. Harriet Dustin, President of the American Heart Association. She's also Vice Chairman of the Research Division of the Cleveland Clinic. Also with me is Dr. Nanette Wenger, Professor of Medicine at Emory University School of Medicine. She is the immediate past Vice President of Programming for the American Heart Association. Dr. Wenger is President-elect of the Georgia Heart Association. Welcome to both of you.
Thank you.
Thank you. Why is it that most women I know don't think that they will ever have a heart attack?
I expect the reason is simply public education. Women have been told literally for generations to take care of their husbands, to keep their husbands from having a heart attack, and have never been told that they are vulnerable. And perhaps this is one of the major messages to the women today. You are vulnerable, although not as much as your husband.
Do you think most women are even aware of the symptoms if they experience them?
I think they'd be like men and would tend to deny them. I think people intuitively know when they're ill. And I think people intuitively know when they're very ill. And if you get a symptom which tells you that you are very ill, it is very frightening. So you deny it.
Right. What are the symptoms? Can we talk about that a little bit?
Again, most people think that, or are told that, the major symptom of heart attack is pain. But as it's perceived by many people, it is not the kind of a pain that you get with an injury or with appendicitis or something of that sort. The symptoms of a heart attack are very often a discomfort, a pressure, a heaviness in the center of the chest. It may not always be pain, as most people know and understand pain, but it is an unpleasant feeling in the center of the chest. It usually lasts for several minutes. But very important is that it may go away. That doesn't mean that the problem is resolved, because it may come back. The pain sometimes may go up into the neck. It may go into either one arm or into both arms. Sometimes there's associated sweating and nausea and vomiting. But it is the discomfort, the heaviness. I've had some patients tell me it feels as if an elephant were stepping on their chest, or if a hot burning poker were just poked into their chest. But these patients, even though they do describe the pain as being bad, don't describe it as pain.
I'd always imagined that it was sharp, sharp pain.
No, it's not sharp pain.
Over here in the chest, but you talk about the center of the chest.
Again, if you look at the Valentine cards that'll be coming out in a couple of months, the heart is always over on the left side. And many people think that heart pain should be way over on the left. Well, the heart really is just underneath the breastbone to a great extent, so that the pain that you get with heart attack is pain in the center of the chest, under the breastbone.
How do you know what to take seriously and what not to take seriously, Dr. Dustin?
That is a very difficult question. I think that one should take seriously any pain that is prolonged or that is very unusual. We all have indigestion, we all have little pains here and there, very frequently. Something that is very unusual or severe, as Dr. Wenger said, a severe pressure or a burning discomfort. Anything that is unusual should be taken seriously. I think the point that one ought to make is that although she described a heart attack, you can have what is called angina, which is the same kind of pain. It's on exercise. It stops when you stop. It comes on when you start again. It can occur after you eat. It can occur in the cold more easily than in warm weather. If you have that kind of thing, then that tells you have a narrowing of an artery that supplies heart muscle, and you should go see a doctor about this.
That is not necessarily instantly fatal, though. It's apt to be more chronic, right?
But it is produced by the same disease that eventually produces heart attacks.
But I think the important thing about angina is that it is typically a brief pain, literally a matter of just a minute or so. And the minute you stop or rest, the pain either disappears or abates. That is really not what happens when you have a heart attack. And perhaps the important emphasis is that if you think you're having a heart attack, or if you are with someone and you think they are having a heart attack, that should signal you that something must be done, not just sit back and say, well, I might be having a heart attack. And the thing that should be done is to call your physician right away, describe the symptoms, and get instructions.
And if you can't get them,
again, if you can't get the physician, don't wait. Go to a hospital emergency room. If you have available a means of transport, don't wait for an ambulance either. The important thing is to get to medical care. And this becomes crucial because more than half of the people who die of a heart attack die before they reach medical care. And these are what we call mechanism deaths, deaths that are due to a disturbance of heart rhythm. And far and away, this occurs in the first hours of heart attack. And it is this mechanism death, this disturbance of cardiac rhythm, that coronary care units handle just beautifully. They can diagnose it, they can treat it, and can increase the survival from heart attack.
Let's backtrack for a minute and talk about who are the people who are having heart attacks. Is it true that more women than ever before are having heart attacks, or is that something we're not sure of?
well, the question has been raised as to whether more young people, young women, younger women, middle-aged women are having heart attacks than before. And I'm sure that you will want to get into this and its possible relationship to oral contraceptive drug therapy. Women, it's very interesting that at between the ages of 35 to 44, heart attack rates among men are about four times that among women. Whereas at age 60, over 65, they are equal. And women have heart attacks, but they have them at an older age than men do. And in some way, the heart attack is delayed in women.
Well, haven't we been told at times that it's because of estrogen? That the estrogen in some way makes the woman immune? Is that true?
Well, you know, I think
said.
some of this was almost coincidence, simply because the occurrence of heart attack in women after the menopause is much greater. And perhaps it was just coincidence in terms of age, because we tend now to see heart attacks younger. Now, whether they're really occurring more often or in younger women, or whether it's just now acceptable to diagnose a heart attack in a young woman, none of us can say. But when I was in school, when Dr. Dustin was in school, we almost never diagnosed a heart attack in a young person, but particularly in a young woman. Now we're realizing that they do occur. Whether it's new or whether it's just being recognized, we really can't tell.
Why was it not acceptable to diagnose in a woman or
Didn't
or a young person?
happen.
What do you mean it didn't happen?
You mean it didn't? We were not taught that it happened. We were taught that it didn't happen in young people.
We've learned a great deal more about coronary disease, the disease of the artery supplying the heart, over the last several years, simply related to improvements in our ability to diagnose it. Before, we were totally dependent on the story, on the history the patients gave us. And now we have a way, in a well-living individual, to outline by X-ray pictures the coronary arteries in the heart to see the degree of obstruction. And this really can tell us an awful lot, whereas before we only suspected it. So now we are really becoming much more accurate, and this is a test that literally thousands are being done each year, many of them as a prelude to heart surgery, many just to confirm the diagnosis or to disprove the diagnosis.
But that's not essential to any diagnosis, though, is it? I mean,
I don't think it's essential, but more and more we are seeing this test being done. It's called coronary angiography or coronary arteriography, and it is being done more and more because we are finding that it is a simple test, it is a safe test, and very often it gives us information that was crucial to have in terms of taking care of sick people.
Okay, maybe it isn't necessary, as you say, but I think you should be aware of one thing, and that is you can have heart pain without disease of the coronary arteries. This is now well known, and as far as I know, this is more in women than in men. The arteries can go into spasm, but they can look perfectly normal. And the only way to make that diagnosis is by looking at the blood vessels. If you want to make you can make a diagnosis of a symptom. If you have angina, you have angina. It's very characteristic. It comes on with exercise, with cold, with anxiety, with emotion. But if you want to tell why the person has angina, you really have to look, don't you?
This is the very important thing, that there are many disease states that cause chest pain or heart pain. Coronary disease is just the most common among them.
See, I think we're not aware of that usually.
And
they say pain in the chest, heart attack.
Right.
It's not. And this is important to realize, because many people who are so terrified of heart attack don't seek medical care for something that might be helped by medical means by another approach. And very often it's just as important to do a test, a diagnostic test like angiography, to delabel a person, to say they don't have coronary disease, because that may be important for the way they intend to conduct the rest of their lives. It may be important for their occupation. So it's a test that's being done more and more.
I was so surprised to find out that 60% more women have heart attacks than have cancer. I mean, we all spend so much time being afraid of cancer.
That's right.
And heart attack is just not something that it enters our mind, but we think of overweight men who are hyper-executive types, and we just don't connect it to ourselves, really. We're so much more frightened of cancer.
Women are really vulnerable, and this is why it's so important that they understand this, because after 40 years of age, heart attack is the most common cause of death in women. And it's not easy to see the woman who has had a heart attack. It's an invisible illness. It doesn't leave an external scar. It doesn't leave any disfigurement. So that there are many people walking around who've had a heart attack, and they certainly don't carry a sign that says it. You can see disfigurement with many other illnesses. And I expect that's not one of the reasons that we're not as aware of it as we should be. But women have more high blood pressure than do men. More women are obese than are men. More women have a high blood fat level, a high blood cholesterol, than do men. And now women are beginning to catch up in terms of cigarette smoking. And we know these features as the so-called risk factors, factors that tend to predispose an individual to coronary disease.
Let's talk about a possible risk factor that you mentioned earlier, and that is the birth control pill, oral contraceptives. That's on a lot of people's minds, women who are taking the birth control pill. Am I putting myself in danger of a heart attack? What's your feeling about that?
Let us look at one aspect of it before we do that, because it's a question that was going to come to your mind and to your viewers' mind very quickly. If you say that women are protected from diseases, particularly diseases of the blood vessels, because they have naturally occurring estrogen before they're menopausal, then why should oral contraceptive drugs, which are mostly a combination of estrogen and progesterone, why should they be associated with an increased occurrence of blood vessel disease? The answer is nobody knows. But they are. And not only so in women, but in men, because the first recognition of this came years ago when there was a study of the effect of estrogen on, first on coronary heart disease in men, and second on prostatic cancer. Because it's obvious, you know, a man is different from a woman in the fact that he doesn't have estrogen. Give him estrogen. The fact that he gets breast enlargement and loses his sexual potency and all this stuff is, that's unimportant because he's alive and you're doing him good. Well, it just so turned out that although it might have been good as far as prostatic cancer was concerned, the death rate and morbidity rate from heart and blood vessel disease rose among these men. So as far as men were concerned, that became apparent. And then as far as women are concerned, although it's not a numerically terribly significant thing, everybody that takes contraceptive drugs should realize that they are at increased risk of having high blood pressure, heart attacks, thrombophlebitis, and one of the consequences of venous thrombosis, and that's pulmonary embolus.
Is it mostly the heart attack caused from blood clot that people have who are on the pill? Is that Is that the kind of...
I don't think so.
No?
We are beginning to see actual disease in the arteries of the heart that seems indistinguishable from the disease that we usually call coronary disease. And I think, Sandra, there's another point that we want to make, and that is it's not only the oral contraceptives that put people at risk, that put women at risk, but the estrogen therapy that is given after the menopause. Remember, we said that the postmenopausal woman, unmedicated, is more prone to heart attack than the premenopausal woman, and incidentally, this bears no relationship to whether or not they've ever had children. Childbearing doesn't seem to affect it either way. But here we take a postmenopausal woman at increased risk of heart attack and give estrogen, which we now know predisposes to heart attack. And I guess I was really amazed to look at the statistics, which even I didn't realize, that probably half of the women over 50 years of age in this country today have had some kind of estrogen therapy for at least several months. And about the average use is maybe 8-10 years. So that here are women that are taking medication for symptoms and are putting themselves at an increased risk of heart attack.
That seems irresponsible.
On the part of whom?
The people prescribing estrogen to postmenopausal women.
Oh, hold the phone. Because these data are only beginning to come to us.
Mm-hmm.
A woman comes to you, you're a physician, a woman comes to you and says that she is miserable with hot flashes, sometimes with very severe headaches, hot flashes waking her up at night. What are you going to do? Say, there, dear, this is something that all menopausal women have to bear? Or are you going to try to help her? You're going to try to help her. You know how to, you'll do it. And that was the way it was for 10, 20, 25 years. We're now beginning to weigh the possible consequences. Eventually, I suppose it will be up to the woman. And you'll tell her, I can prescribe this medicine for you, but you must realize that you may be at increased risk of developing a heart attack.
What I was trying to get out of you was I wanted you to say whether you thought that some of these drugs ought to be taken off the market and we ought to stop prescribing them. That's not how you feel, is it?
No, it's not how I feel.
Not yet, because these are very troublesome symptoms that can be incapacitating to some patients. But here is where judgment is concerned, and I think the patient should have a part in the decision making. And the decision goes something like this. If these symptoms are really intolerable, perhaps 2 or 3 months of therapy and then trying to taper would be appropriate. I think there are many women who may need therapy for several months and who can be tapered, who don't have to stay on estrogen therapy for life. I think there are many patients who, when they know the alternative, symptoms on one hand, heart attack on the other, may be willing to try to tolerate the symptoms and try some other medication. But I think there is also a responsibility both of the healthcare community and of the consumer, and that is to see that there are funds available for research so that we can have a safer oral contraceptive, because this is a very important medication in today's society, and so that we can have safer postmenopausal therapy to combat symptoms. It does not have to be estrogen. And if there is enough interest and enough emphasis that the medications that we have today are not sufficiently safe, the risk-benefit ratio is not what we want, then we will have the appropriate funding for research.
Is there research going on now at all?
There is some.
But there's no massive program.
But I expect one of the things that's troubled me in recent years has been the climate in this country about scientific and medical research. I've heard too many people say we have enough new information that all that has to be done is to translate it into the care of patients. While that may be true immediately, if we do not have continuing research, 2-3 years down the line, there will be no new information with which to improve patient care. And I see this as a major need of today's society.
You don't agree, do you? Or do you?
Oh, yes, I do agree.
Oh, you're shaking your head. I didn't know.
Oh, yes, I do agree, because there are all kinds of things that we can do now, but there are all kinds of other things we cannot do. We cannot, for instance, answer the question that I asked a minute ago. How come a premenopausal woman who is supposedly protected from heart attacks by her estrogen takes estrogen and has more disease of the heart and vascular system? How come when she is menopausal and takes estrogen and then converts herself back somewhere to where she was premenopausally in regard to estrogen levels, how come she's at greater risk? Strange thing. Nobody knows the answer to this. And this answer would be extremely important to come by. Another case in point. How come obesity predisposes to high blood pressure? It does. Nobody knows why. We don't know how to prevent high blood pressure, to say nothing of curing it. Well, these are just two cases in point, and very important ones.
You know, there's another fascinating bit of information, and this comes out of a study that was done over the past 20 years in Framingham, Massachusetts, on people who developed heart attacks. And one of the things that's been found is that the woman married to a man who has a heart attack, on a statistical basis, loses all of her protection of being a woman. The woman married to a man who has a heart attack, as a group, would have the same incidence of heart attack as men.
At an older age?
Apparently not. Apparently the protection is gone. And this raises the whole question of what does environmental factor or factors have to do with heart attack? What is there about this household, if you will? Is it stress? Is it lifestyle? Is it physical inactivity? Is it food? Is it smoking? What is this constellation that suddenly makes the woman married to a man who develops a heart attack lose her immunity, or
It's
relative
catching.
immunity?
You mean heart attack is catching?
The environment may be catching, and much behavioral research is necessary because there is something in the lifestyle, and whether it is a specific component of food or cigarettes or what, or whether it is the ambience in the household, I don't know.
Well, there
It's
is no
fascinating.
absolute proof that stress causes heart attack, right?
As far as I'm concerned, there isn't.
And stress is part of life. Can you imagine how people would be if they weren't stressed? They'd vegetate. I'm not sure that stress is all that bad. It may be that inappropriate or excessive stress is bad. But I would hate to think of a life without stress, wouldn't you?
Or
Well, we had a
inability to cope with it.
conversation last night about this,
Yes.
and we were talking about the type A personality, which is supposedly the person who has heart attacks most frequently. You might describe what a type A personality is.
A type A personality is one that is a personality that's very time conscious, that takes responsibility very well, or likes to take responsibility. It may not take it well in regard to the personal cost that it is, who is an achiever. And I don't know what's wrong in being an achiever. And I do not think that although there's been much said about the type A personality, it isn't always associated with a greater risk of
Well, there
heart
has
attack.
been some controversy about that.
Right.
There are people who are now
Great deal of
disagreeing.
controversy
Yeah.
about it.
And actually, there was some new information presented not too long ago that suggests that there's a major difference among the type A individuals between those who succeed and those who fail. And that the type A strivers who achieve, who meet their goals, don't seem to have that much of an increased incidence of heart attack, but that it is the type A personality who does not meet the goal. So perhaps the message is if you have to be a type A, you'd better be a good one.
Failure causes heart attacks. That's very interesting. There's one thing that I wonder if you're concerned about, because I certainly am, and that is the fact that to date there is no warning on either the birth control pill insert about heart attacks. And I'm not sure whether there is on the drugs that are given postmenopausal women. But I think that should be there, don't you?
Yes, and I would assume that the FDA will assure that it will be in the months to come at least.
It is supposedly going to be there in the future, but the dates keep being moved ahead all the time.
Well, some of the medical literature suggests that this is imminent, that there will be warnings for the oral contraceptive agents, and probably they will stress two things. First, that women, particularly women over age 40, are at increased risk taking the pill, the oral contraceptive agents. And secondly, that all women on oral contraceptives who are going into the hospital for elective surgery should probably stop the oral contraceptive agents some period of time before their surgery. One of the things that we know is that people who undergo elective surgery have an increased risk of clot forming in their leg and then going to the lung just because they're immobilized and maybe some other things during the surgery. The fact that the woman is taking oral contraceptives increases this risk. Again, another problem that we identified before. When a physician takes a history from a woman, what medications are you taking? Many women don't consider oral contraceptives a medication and don't list this, so that the physician may not be aware the patient is taking oral contraceptives, may not remind the patient to stop before elective surgical procedures.
We're almost out of time. Would you both come back next week and perhaps we can talk about high blood pressure and obesity and rehabilitation?
Be delighted.
Sure will.
Okay, thank you very much. Thank you for watching, and good night.
This program was produced by WNED-TV, which is solely responsible for its content. Major funding was provided by public television stations. Additional support was provided by unrestricted general program grants from the Corporation for Public Broadcasting and the Ford Foundation.